Hello, and welcome to another in our series of webinars from Purview. My name is Les Trachtman. I'm with Purview, and I'd first like to go over a few logistics for this webinar, and then I'll introduce our guest for today. First of all of your microphones of the participants will be, other than we here on the panel, will be muted. The session will be recorded, as you just heard. You'll be able to get that replay after shortly after we're done with this. It'll be posted on our website. If you have any technical issues, we suggest you log out and log back in. That's the best you can do right now. It's hard for us to do technical support on these in real time. And if you have any questions for our panelists, please add them to the Q&A bar at the bottom of your screen. We'll try to answer as many questions as we can towards the end of the webinar. So good afternoon to you, at least good afternoon to you if you're on the East Coast. Welcome to this webinar. It is Brain Tumor Awareness Month, so it's pretty appropriate that we have the topic and the speaker that we're going to have for today. First, let me give you a couple of pieces of information about second opinions, which is a portion of the topic of this webinar. Second opinions are becoming a more common request of a patient who receives a critical diagnosis. Just on Tuesday of this week, we spoke to Dr. Thomas Schwab of Roswell Park Comprehensive Cancer Center, and he said in our webinar that it is every patient's right to have a second opinion. That's probably why the worldwide business for medical second opinions is approaching almost a $10 billion with a B dollar business. But even more important than the magnitude of the market is the importance of these secondary reviews. A study by the Mayo Clinic found that more than 80% of second opinion cases they reviewed resulted in a recommended change in the treatment of the initial diagnosis or the initial diagnosis and treatment plan. Our webinar today is focused on children with our guest, Dr. Jesse Skoch. Dr. Skoch is a neurosurgeon at Cincinnati Children's Hospital, one of the top 10 children's hospitals in the country. Dr. Skoch is a brain, skull, and spine surgeon with special interest in epilepsy, brain tumors, hydrocephalus, craniostenosis, or stenosis, sorry if I got that wrong, and the spine. His practice includes a cutting-edge, minimally invasive technique called neuroendoscopy, which allows surgeons to reach areas of the brain through smaller openings. So welcome, Dr. Skoch. Thanks for joining us.
Thank you, Les.
Would you mind, Dr. Skoch, starting out by just giving us a bit more on your background and perhaps a little bit about Cincinnati Children's?
Sure. So I've been a pediatric neurosurgeon at Cincinnati Children's now for 7 years. As you mentioned, my particular interests are in epilepsy surgery and especially craniofacial surgery. The hospital has a total of 5 neurosurgeons here, and we're a level 1 trauma center. We see a large volume of pediatric patients, and we treat all pediatric neurosurgical diseases, but each one of the neurosurgeons here has subspecializations as well.
That's great. Thanks for that. I'm going to ask you a little bit more about any special stuff that you're doing in terms of your research, et cetera, when we're done with this. But if we could start out, I know that you've been involved in second opinions, and in fact, remote second opinions there at Cincinnati Children's. Can you tell me a little bit about that and perhaps give us an example of a recent one, obviously without the PHI attached to it?
Yeah, the remote second opinion system, or online second opinion system, as we call it here, is relatively new to us. I was an early adopter of that system because I've been well aware prior to that of the value of second opinions. The major advantage of the online second opinion system is opening things up to a much wider audience. So we used to get primarily regional second opinions, and now we're looking at second opinions on a national scale. And so that's really been the major advantage of it. I think second opinions are extraordinarily valuable, especially for complex patients, and especially for situations that require multidisciplinary approach. It's one thing to have one surgical service involved, but when you're talking about a team of surgeons, there can be conceivable weak links, either because the hospital doesn't have a super specialist in that area, or the surgeons haven't collaborated previously on that particular disease process. And so finding something where you have a rare disease and a team that kind of meets all the different subspecialization needs is really important. And so second opinions are a great way to search that out, especially with online second opinions, without families having to spend a lot of time traveling or waiting for clinic appointments that can take months to obtain.
Understand. And I think that's completely consistent, the multidisciplinary review, with what we heard actually from Dr. Schwab on Tuesday. But just to get into a little bit more of the detail, a remote second opinion is obviously different than examining a patient in person. Could you tell us a little bit more about that, and what are those differences?
Yeah, absolutely. So one of the big differences is it's absolutely critical to have good records for a remote or online second opinion. Second opinions that are in person, it's also certainly nice to have all that data, but you're really relying a little bit more heavily on some of the outside documentation. Now, fortunately, the majority of patients that are seeking online second opinions have already obtained, quite a bit of medical documentation. They've seen specialists, they've seen their pediatrician multiple times. They've had recent exams that we can look at, and we also have the ability, if need be, to request additional documentation or even contact providers to get more information if necessary. So I think that the biggest difference is relying more heavily on data from the medical record with the online second opinion. But fortunately, that has not been a significant issue, in the sense that the data has been of good quality.
Great. So if I, God forbid, have a child that I think needs a second opinion, and I want to contact Cincinnati Children's, how do I go about doing that?
Yeah, so on the Cincinnati Children's website, there's a link to the online second opinion, or OSO as we call it internally, and that can be that'll bring up information. It'll also bring up information about eligibility, depending on the region that you're living in the U.S. There are some areas that are eligible or not eligible, but fortunately most of the country is eligible for it, and that information is all available. We also sometimes provide that information via phone call. We'll get a phone call to our neurosurgery clinic with someone that's specifically seeking a second opinion, and if they're out of state, we can't do our conventional kind of telemedicine type consults with them, but we'll specifically then forward them information on the online second opinions system, so they can take advantage of that.
That's great. Obviously during the patient journey, so again, back to that scenario of I have a child that needs a second opinion, or I think needs a second opinion, when would you expect to hear from me? So what would I have done already before I contact you for this online second opinion? Or maybe answer the second part of the question as well, which is, what would be the optimal time for you? When would you like to see me or see my information?
Yeah, I think it's important to make sure that it really is a second opinion, first of all. I mean, if you are referred to a neurosurgeon, I think it's most reasonable to see someone in your region that has, as long as they have that expertise in whatever your particular disease process is, rather than, as soon as you get that referral, seeking out a subspecialist, out of your locale. And that's really helpful for the subspecialist out of your locale, like myself. If I'm getting a second opinion, to see that subspecialist documentation. It's not nearly as helpful for me to just read the primary care provider's notes on the initial diagnosis. I think it's also, neurosurgery relies very heavily on imaging. And so If you see a neurosurgeon and decide you want a second opinion and they've recommended that you obtain an MRI, a CT scan, or any other diagnostic imaging, I would recommend proceeding with that at least. And that can also give them new information. They probably won't have a fully formed opinion until they've seen some of that data. So I think making sure that it's not too premature. And then I also think that there are some conditions where your focus really shouldn't be on second opinions. And those are things where if you're seeing an expert or subspecialist and they're telling you that this is something of urgency, then I think you should proceed with caution as far as taking that time to get a online second opinion.
And obviously, at least based upon the information that I used in the preface about the Mayo Clinic study, there will be times when you'll review a prior opinion and you may come up with different treatment options for that patient. How do you help the patient navigate when there's two differences or there's different alternatives for them?
Yeah, I think providing them reasoning helps, not just simply giving them an answer, that your prior surgeon recommended treatment A and I'm recommending treatment B. That leaves them very in a dark spot as far as trying to pick. And so I think that you need to explain, why you're recommending that. Is that something that you have more experience with? Are you not comfortable with answer A? I mean, the best the best solution whenever possible is when I can tell someone I'm very familiar with what your surgeon is recommending. However, I perform that procedure and I also perform this other procedure. And I think for you, based on the records that I've reviewed, in my experience, you're going to have a likely better outcome if we do this alternative procedure. And here are the reasons why I think that this is a better fit for you. And I think, in some cases, there can be what we call equipoise, where there's two different answers to the same question, and it's just really not clear what the better answer is. However, that's where I think having a discussion with the family can be helpful, because it might not be clear cut that solution A is better than solution B when I review the records. But when you start talking to families about things that they like, don't like, or things that they might fear or not fear for their child, it can become a little bit more evident. For example, if someone really doesn't want to have to do frequent follow-up visits, there are some procedures that won't require that as much. If someone wants a shorter hospitalization, but is willing to undergo secondary procedures, then that can affect your choice, for example. So there does need to be some back and forth sometimes with choosing that procedure. And I also think that it's very reasonable, once you offer an alternative procedure, to encourage the family to discuss that option with their initial provider. So you can get some additional feedback that way. Is that, why didn't that provider offer solution B? Is it because they don't believe it's the right solution, or is it just something that they're not as familiar with delivering it outside of their comfort zone? So I think having some back and forth after you've offered a different solution is very important.
And then, excuse me, the natural question after that is, okay, so the patient has received an initial opinion. They've come to you or one of your colleagues to get a second opinion. You've had this discussion, and it turns out that what you've recommended is what they want to do. Is there an opportunity then for us to come visit in person and perhaps have a procedure at Cincinnati? How does that work?
Yeah, absolutely. I mean, that's the expectation. If I'm offering a different solution, the majority of the time, if that's what the patient's interested in, the presumption would be that they would want to come here to have that done. We won't do that without an in-person evaluation first, and I think that that's really important. I personally think that offering a procedure, and then, as good as the records and the imaging are, having the patient just show up and seeing them for the first time as I take them back to the operating room is is not the best solution, because you do, as good as those reviews are, you do miss some of the nuances of seeing a family, having that back and forth conversation, and seeing the child for an in-person physical exam. So the next step for us, at least, would be always to bring that patient in for a clinical visit. That's also, we try as much as possible to coordinate if it's going to be a multidisciplinary approach, so that when that patient comes, they're either seeing myself and the other surgeons that are going to be involved in the procedure simultaneously, or at least during the same day in serial, so that they can get all that done in a short period of time. And then we can expedite scheduling the surgery for them. In some cases, we can, if there's a high degree of confidence, we can set up those in a kind of a back-to-back fashion, so that the patient will see us, have their evaluation, and then stay in town for a few days or a few weeks, and then we'll subsequently make sure we have everything ready for them for a pre-scheduled operating date.
Okay. And just to take that to the next step, let's just assume that that occurs. They've come from, we'll call it a long distance, to Cincinnati for you and your colleagues' expertise. They get a procedure done, and then ostensibly they return home. How do you deal with that? What's the post-surgical connection?
Yeah, that can be a challenge, and so that's a case-by-case basis, depending on how far the patient is traveling, what their resources for coming back are. Ideally, we would like to treat them like we would treat any of our patients here, which would be to have in-person follow-ups on a pretty regular basis. But sometimes we have to make accommodations for that, and sometimes that can mean requesting that they stay locally for a certain period of time, where we know that there can be more acute issues or problems that could conceivably come up, and you just want to have them close to address those in the short term. Other times it can mean extending their inpatient hospitalization by a little bit longer, to make sure that they're observed longer than we would typically keep patients in the hospital if they were local. Often we will just do simple things, like if it's just, a lot of times we like to have like a 2-week wound check on a patient. We'll ask them to see their pediatrician, make sure that they don't have any concerns, and or send us some photographs of the incision, make sure that we can take a look at it, and then just get on the phone and make sure that there's no concerns with that patient. For things that we require imaging on, we can often have patients obtain outside imaging at their local hospital in follow-up, and then we can have that transferred to us and analyze that and get back to the patient via telephone. We typically like at least one follow-up inpatient, in-person visit, if possible, at either 3 months or a year for most of these cases. But again, there's some flexibility and options. Sometimes we will have them return to their local subspecialist, whoever gave them the first opinion. We always remain available for communication, but we can sometimes have them at least assess if there's any complications or issues that need to be addressed, that someone like a primary care physician might not be able to sniff out.
Great, thank you for that. So before we open it up to audience questions, and I know there are a few already from the audience, I wanted to give you an opportunity to talk a little bit in a little bit more detail about some of the specialized research that you're doing there. I don't know if you're running any clinical trials, but anything like that. But before you do that, tell us a little bit about cooking with your kids, because I know that's one of those things that's important to you, but it is something that we talked about in the preview.
Yeah. I don't get a lot of free time, but when I do, I like to spend it with my wife and my 9-year-old and my 4-year-old. And cooking is something that brings us all together. Everyone loves food, and I want to teach my kids an appreciation for food, and teach them that things tend to be better when you make them from scratch or make them yourselves. And so getting their hands messy and cooking Indian dishes, Mexican dishes, whatever we happen to be into, it's one of my favorite things to do with them.
That's great.
And
so tell us a little bit more about the research side then.
Yeah, so I actually run a basic science lab in addition to a number of different clinical studies, and my basic science is studying different ways to detect seizures in patients. So specifically, I won't get into too much details, but basically using optical sensors to see seizures, literally kind of see seizure activity across the brain as a new way to detect seizures rather than simply using electrodes on the brain, which is how we see seizures currently. And so that's like stuff that, you know, won't unfortunately be entering the clinical realm for, you know, probably on the scale of a decade or more, but that's how it's got to start. In the kind of more real world, feet on the ground clinical situation, I have a number of studies, and you know, one of those things that I like to talk about that's kind of relevant to the second opinion story is that a lot of the second opinions that I see are for patients with craniosynostosis or abnormal head shapes that are so severe that they require surgical correction. And a big project we're working on is really more of a quality improvement study than a traditional research study. And we're trying to figure out ways that when those patients do come here, especially if patients are traveling from afar, we kind of hone in on what we call their length of stay, or how long they're in the hospital for. And it's a fine line between making sure that the patients are comfortable and safe, and putting them at risk for hospital-acquired infections, or you know, becoming uncomfortable because they're stuck in the hospital for so long, and kids and families don't want to experience that either. And so we're working with a quality improvement center that we have here at Cincinnati Children's to make some interventions in an organized way. So different kind of post-operative treatments, you know, sometimes simple things like applying ice packs to the head to reduce swelling. Other times, some more complex changes that we're looking at, like medications that might help with not requiring as many narcotics that can have side effects but still can manage pain. You know, using things like temporary sedation when patients are in the ICU to keep their vital signs normalized and diminish the need for pain medications. And so we're kind of tracking that data and trying to optimize it with, you know, real discrete interventions to find ways to safely shorten how long patients are in the hospital and get them out safer and more comfortably in an organized way.
Great. Well, thank you. We all thank you for the great work that you're doing there, and the help that you give to the patients that you get to see. What I'd like to do is take a few questions from the audience. We have just a few minutes left before we have to close up, but there are a few. So the first one comes in, actually relates to something you said earlier about second opinions, but they asked whether they might use the second opinion system at Cincinnati Children's to get a pre-surgical review. So is this something I should be talking to one of the surgeons about? Is that something that happens there?
Pre-surgical review, I guess, to clarify, pre-surgical review meaning that the patient's already been seen by another surgeon, they have a surgical plan, and verifying that I think that's the right plan, or before even seeing a surgeon?
This was asked by one of our participants, so I will just say, let's do it before they've seen another surgeon.
Yeah, that's doable. It's not impossible as long as there's enough data to do that review. And again, that we rely in neurosurgery pretty heavily on that imaging data, so it needs to be up to date imaging data, and you know, at least some good quality medical records. Again, I would reiterate, for the most part, I think if at all possible, it's pretty reasonable to talk to someone local first. And you know, as much as I love bringing patients in and from afar and treating them, it can be a stressful thing for families, as you can imagine, to travel and have their care kind of fragmented in a new place. And so I think if there is a local option and that you feel comfortable with it, or at least are included in your decision making, I think it's a reasonable thing to look locally first whenever possible.
Okay, good. I think that's good advice. A somewhat related question that came in from the audience. Are you willing to, or are you available to do an online consult with my physician, my local physician? So let's assume I have a specialist at home who says, I'd be more than happy to talk to Dr. Skoch and see what he thinks about this.
Yes, I think that it is probably helpful to go through the motions of the online second opinion program first, because otherwise it's going to be essentially kind of a phone call type communication. And inevitably, if that person is telling me about you or your child, and telling me about what their plans are, it's going to be a little harder there's going to be bias introduced in that inevitably, even if they try not to, and it's going to be harder for me to kind of critically assess the big picture situation. And so I would say first, it would probably be better to go through the online second opinion process. Let me look at all the information, request any information that might be missing from the record that I think is important. And then once I have that and I've reviewed that, I'm perfectly willing to have a conversation with the primary specialist. I think you want to be careful. What I have seen sometimes happen is, patients might like what I'm offering, for example, and then try to convince their local surgeon to kind of do what I'm offering. I don't think that's a good idea. You don't want to try to push a surgeon out of their comfort zone. I think you have to kind of choose the place and the person that is the best fit for you, rather than try to get someone to bend their plan based on what some other expert is saying. And I think it's important to remember, if you get a second opinion and that you kind of like or that appeals to you, it doesn't necessarily mean that it's the right answer. It's just it's a different answer. And so and sometimes third opinions are necessary when you've got two different situations and you're feeling some uncertainty. That's when kind of these tiebreaker opinions or third opinions can be helpful.
It's a good point. I know that HHS and Medicare are not necessarily related to children, but they will actually reimburse for a third opinion if there are two conflicting, a first and second opinion. So that's great. And I'm going to put our coordinator on the spot for just a minute. I know we have a slide somewhere of the Cincinnati Children's website with the access point to second opinions. Samantha, is it possible for you to share that screen with us just quickly? Sorry to take you out of order. There it is. So important to note, I think, for Cincinnati Children's is that you all think it's such an important part of what you do that it actually comes right off of your homepage. So there is a pull down on the homepage right there where you can get that second opinion. Thanks, Samantha. I thought that would be appropriate there. Great. Okay, so we're going to wrap up then. Thank you so much, Dr. Skoch, for joining us today, for providing us with the information regarding how you do what you do at Cincinnati Children's and some of the things that Cincinnati Children's is involved with. So we very much appreciate your time today. As I mentioned, this webinar has been recorded. If you want to listen to it again or share it with a colleague, it will be posted very shortly to the Purview website, and you can find that off of the Learning tab at the top of the Purview website. That's purview.net for those of you who are not familiar with it. Don't miss our next in a series of webinars coming up on May 25th. That's at the bottom of your screen at 1 p.m. Eastern Time. This one will deal with the very sticky issue of how a physician can issue a second opinion to an out-of-state patient. There's lots of issues on licensure, which has become an obstacle for physicians and organizations being able to share their unique expertise with patients in need in certain geographies. We've got some groundbreaking research that has exposed a very firm legal ground for enabling these opinions in just about every state and territory in the US. So good news on that front. And I think that's beginning to be more accepted, and the states have been very good about expanding to there. And then as a follow-up to this, you can see the guide to second opinions that was produced by Dr. Skoch. We've got Second Opinions 101, which Purview wrote in conjunction with the advisory board. And then there's an article on Cincinnati Children's online second opinion system that's also been written in conjunction with the advisory board. So thanks for your attendance today. Thank you again, Dr. Skoch, for your participation, and we'll see you again next time on the next webinar.
Thank you, Wes.